I think it's time for us to get started. I want to introduce Wendell Strickland, the CEO of Strongside Solutions, and also Mike Bodker, who's the former mayor of the city of Johns Creek, Georgia, which has a population of 90,000. And he's also a government relations person for Strongside. His company is Peak Global Strategies. So we're going to go ahead and get started. I'm going to pass things over to Wendell, but I want to start real quick and just say how excited I am to be bringing you guys Strongside Solutions. We hear from our cities, and we know from TML our own premiums have been going up rapidly over the past few years, and everybody's looking for solutions to rising costs, but wants to maintain the delivery of meaningful benefits because that's a real advantage that our government entities have in hiring people. Strongside has some real solutions, and we're going to get into those today. I'm going to let Wendell get started and tell us how.
Hey, thank you so much, Mark. Hey, everybody, I'm Wendell Strickland. I'm the CEO of Strongside Solutions. I've been blessed to be a leader in this company for quite some time and to have worked for several other large consulting firms in the past, which really kind of helped us craft our solutions here. We're going to have a little bit of fun. We're going to have some interesting conversations, and we're going to tell some good stories. So hopefully that meets everybody's expectations. And I think it starts with this. You know, I don't know about you guys, but my mom used to say, "Oh my goodness, we put a man on the moon and put in whatever you want. You can't cut the yard today," or whatever it is. And it's interesting that we put a man on the moon, but the industry is saying, brokers are saying, the carriers are saying that you can't enhance benefits while lowering cost. Well, I think that's incorrect, and hopefully, through the end of this, we can kind of get through that conversation and have some fun with it. Interestingly enough, Reuters, however you say them, is saying that you can't do it either this year. Specifically, they're kind of, and we have to go through the charts first, okay? So the fun part starts after this, but they're saying that due to a lot of things, and pharmacy being one of them, that everybody this year in 2024 is looking at the baseline, what we call trend, or the baseline increase, if you're running well, is about 8.5%, which is the highest it's been since well before 2014. So it doesn't look good. And I put kind of a chart down there, some of the drugs they're talking about, of course, which might be some of the gene therapies and some of the other things are fairly expensive when you're looking at $500,000 or $160,000 per treatment, $2.7 million per treatment. And we actually have an example in our presentation how we kind of helped with that. So the trend is that, things seem to be going up. I think this is a great slide. This is part of the Kaiser Family Foundation. And it demonstrates, if you look at the blue line, those are family insurance premiums. If you look at the orange line, those are employer contributions to those premiums. And it clearly shows that employers just can't keep up, specifically with the family tier of insurance premiums, okay? So that's probably not a surprise to anybody. Then let's talk about what is healthcare. In America, we have employer-sponsored healthcare and we have government-sponsored healthcare. And if you look at, 91% of the people are covered by some kind of healthcare in America. You look at that as about, 300 million people. And you look at how much of that, which is 60.7%, is covered by the employer, people under the age of 65. That's 180 million people. So 180 million people get their healthcare through employers like the attendees on this call. So it's a big number. It's a lot of people. And as you saw, it's getting more and more expensive. Now, probably 10 or 15 years ago, we had an epiphany. And as a insurance consultant, a broker, whatever you want to call us, the people that are supposed to help you find solutions to access to care and cost of care to your employees, we kind of had an epiphany, and that is, what is the USA healthcare system? And we noticed that the people that provide access to care are carriers, insurance carriers. And what carriers do is they contract with doctors and they provide networks, and those networks are distributed to you and your employees, and then they have access to doctors and hospitals and those kind of things. And every single one of those companies is publicly traded. So what we really have in America is a shareholder value healthcare system. And how do you create shareholder value? The companies have to charge you insurance premiums more than what they spend so they can give profits to their shareholders. And they're doing a really good job of it. I mean, if you look at top left, there's United Healthcare at 600%. I mean, if you'd invested in their stock in 2016, you'd have made a 600% profit. But the only one that's really kind of not doing so great, and it's just more recently than anything, is CVS Aetna. But they were at 700% back in 22 as well. Cigna's at 300%, and Anthem, Blue Cross, Elevance, whatever you want to call them now, they're at 521%. So we realize that the U.S.-based healthcare system is a shareholder value healthcare system. And if you pull their 10Ks, their annual reports, there's something in there called a 10K. And if you look at their 10Ks, you will read that they are dependent on increases in premiums to employers to make their shareholder value dividends. It's right in their annual report. So if you're depending on United Healthcare, Cigna, CVS, Aetna, Elevance to provide you answers to lower costs, they just can't do it. They depend financially on increasing those premiums to you and your employees. So that was the first thing we kind of noticed. We also noticed that the same thing existed with large national insurance brokers, the publicly traded brokers. If you pull their 10Ks, truly inside those documents, it states exactly the same thing. Their shareholder value, they can't create solutions at lower cost because they depend on those premiums to drive shareholder value. And here they are. Marsh McLennan, Aon, you look at the top 13 brokers, they're all right there. And if you look at those insurance brokers, they have the same shareholder value conflict. So what we realized is we can't do anything if we want to continue to use carriers and if we want to be a publicly traded company. And I work for 2 publicly traded companies, and I can tell you, their incentive is to drive value to their shareholders, not to drive value to clients. Okay, so those are a lot of the slides. We just kind of wanted to get a financial baseline and get you on the same page of where we were kind of 15 years ago. And we said, aha, how do we do this by utilizing those carrier networks, but not have the same conflict of interest? And how do we not have the conflict of interest as a consultant? So then we started looking at these carriers. What do carriers do? There's only 4 things in healthcare. There are hospitals, there are doctors, there's medications, and then things not done in a hospital setting, they're called ambulatory surgical centers. I mean, that's it. It's a big, multi-billion-dollar complex system, but it only has 4 handles: medical, doctors, pharmacy. That's it. And so what these carriers do is they go around and they contract with hospitals, they contract with doctors, they contract with pharmacy benefit management companies, and they cobble that together, and they call that Aetna, they call that Cigna, they call that United Healthcare, they call that Blue Cross Blue Shield or whoever. And then they turn around and they sell that to brokers or to employers, and then they make it available, and y'all make it available to your employees. So what we said was, somehow or another, we've got to unlock the box. We've got to get inside there so that we can start having control over those individual pieces. And like I said, you can't do it if you do, and we call it like the motherships, the BUCAs. If you go and let the carrier do it all, you cannot unlock the box. You've got to do something better than that. So then there's the funding of healthcare. And what I want to demonstrate on this slide is that healthcare is simply the funding of risk. That's all it is. How much do you put over here to pay for the expenses over here, right? And how do you do that in a way that allows you to have control and to have the same benefits to your employees and perhaps start controlling costs? So if you look at this slide, there's a big blue bar on the left, and there's a big sweeping arrow to the right. So if you look at anything underneath that blue bar, those are all carrier-based solutions. And whether you're under the blue bar carrier-based or whether you're above the blue bar, all healthcare programs, systems, deliverables have 4 elements to them. You have to have an administrator, right? Somebody has to pick up the phone when your employees call. Somebody has to pay the doctors. Somebody has to process the claims, okay? You can buy that through an insurance carrier, or you can buy that separately. Those are called third-party administrators. The next thing you do is you have to have access to doctors and hospitals. That's called a network. So you can go to the left and you can have the carriers offer you the network, Aetna, Cigna, Blue Cross, all those people, or you can rent those networks. I don't know, a lot of people are surprised that you can rent the Blue Cross network, you can rent the United Healthcare network. You have to have medicines for your employees or pharmacy services. So inside of a carrier-based solution, you have pharmacy benefit management, or you can rent or buy services as pharmacy benefit management. And then depending on how big you are, usually around 3,000 employees or less, you have to buy insurance. You have to reinsure your risk, or you have to buy what we call stop loss. And it does exactly that. It stops losses in a couple of different ways to protect your program. So whether you're carrier-based or what we call administrative services or separately purchased, you only have those 4 things to buy. And if you buy everything underneath the blue bar, then you have no control, no data, and higher cost. Once you get above that bar and you move into what we call partially self-funded and fully reinsured, you now have the ability to buy those pieces independent of each other. You have the ability to write words inside of a plan document, which drives behavior of the claims payment system and produces efficiencies. What we call those are optimizers. You can optimize the plan if you can write the words. If you can't write the words, which is anything underneath that blue bar, you can't have any control. So you might know these products as fully insured. Fully insured is where you go to, what's the main carrier in Tennessee? It's Blue Cross, right? Okay, so in Tennessee, you go to Blue Cross and they provide a fully insured proposal. That means they provide you the administration, the network, the pharmacy, and all the stop loss. They give you a premium, they charge it to your employees, they bill you, and away you go. It is the most expensive place to park your healthcare benefits. They will, according to that trend, charge you 8.5% on a good year, and anything that they lose in the previous year, they're going to double charge you for the next year. It is the worst place to be. And if you're above 50 to 75 employees, you should not be fully insured. The next level is called level funded or fully insured, which you can do like a health reimbursement arrangement. There's a bridge there. Then you can go level funded, and then you can go partially self-funded and fully reinsured, all carrier-based. Okay, and all of those have an assigned cost factor to them from 100% loss to an 83% loss, and you're going to lose, or you're going to be that efficient from year to year for renewals. Once you go above the bar and to the right, and you start buying those pieces separately, you drop down significantly and you gain control, you gain data, and you have the ability to optimize. I feel like I'm speed talking, but I kind of wanted to get that out a little bit. And this is kind of where Strongside Solutions, and I'm not really trying to pitch hard our customer, but this is where we started looking at how do you gain efficiencies? How do you build tools? How can you optimize things? What are the best practices you can put in place? What are the things you can do to lower the expense, but enriching the benefits at the same time? And this is kind of where we focus. So when you start looking at fully insured is the black line. Fully insured is whatever you pay to them, you pay, you never get anything back, right? Partially self-funded and fully reinsured is you fund your risk to a level very similar to fully insured, but what you don't spend, you actually keep. And the more optimization you have in that model, the more money you keep. And there's about a 5-year cycle to this. You know, you're going to see some fluctuation, but by and large, you win 4 out of 5 years on self-funded, right? And then on the 5th year, you're only break even. You're still at 100%, which is the equivalent of having a fully insured plan. So the idea here is to move into a product where you can see more green dollar signs underneath your max liability, right? Okay. So once you go and you move away from carriers and you move into the ASO model where you're buying an administrative services, you're buying a network, you're buying a pharmacy solution, and you're buying stop loss, what are your main factors for not, well, how do I say this? What are your main cost drivers that are going to be something you can control in this new model that you couldn't before, but are things that you need to think about? And so everybody knows about high cost claimants. I'll guarantee you, if you're an employer and you're 100 employees, there are 5 people that are spending 50% of your money. If you're 1,000 employees, you know, there's 50 people. It's the same percentage. It's 2%. So what you have in our industry is a low frequency, high cost problem, right? So you might have 1,000 employees And all those 1,000 employees are impacted by 50. So what do you do about that? Same thing with prescription medications. 1,000 employees are impacted by 50 or 100 people taking high cost medications. So we looked at this and we started, listen, we tried everything for the past 15 years. We've looked and looked and looked and tried and tried and tried. And we have come up with some, I think, wonderful opportunities. And as you are navigating your own medical plan with whoever it is that you use to give you ideas, these are the things I think you should think about. So what we did was we said, okay, well, if we have a low frequency, high cost issue, well, and we know that Aetna's not going to help us with it, and Blue Cross, they can't help us with it. What do? So you have to reduce that impact of the few people to the many and make things run smoother. So you have to reduce expenses, not only to the employer, but you've got to make sure your members, your employee spouses and children are also benefited by your services. You can't just continue to make them pay more copays or make them pay higher deductibles or make them pay more insurance premiums, right? You've got to do something different than that. And then when the plan needs to function, when there is somebody that has a heart, stroke, cancer, premature baby, organ transplant, you've got to make sure they get the coverages that they need, right? It has to work. So what we did was we started working on what we call optimizers. Now we developed our own proprietary Benny's platform, right? Our Benny's platform works with all of the carriers, whether it's Anthem, Blue Cross Blue Shield, Aetna, Cigna, United Healthcare. So it's still the same old networks. But here's something that you don't know. If a doctor does an infusion in a hospital, it can be $40,000. If I move that to their home, it can be $1,700. So what we do is we started working on site and location of infusions. Same medicines, same doctors, same everything. But if I'm going to hang a bag of some type of chemical cocktail, if I do it in a hospital, it's $40,000. If I do it in your home, $1,700. Big difference. Dialysis. Most people don't understand that dialysis is considered a disability under the ADA. So what do? We enroll people in Medicare. So now that claim doesn't hit your plan. Plus, you can't do that before about 90 days. So you take something that's running on average about $400,000 to $1 million a year, and we turn that into a $60,000 claim, right? So that's real important. High-risk pregnancies. Most people don't know that gestational weight and duration are considered a disability under the ADA. So why aren't you calling the caseworkers in the hospital and enrolling those people in Medicare? That's what we do. So if you're in the hospital and you have a caseworker walking down the hall, we either send our own caseworkers in there, or we have people that contact your caseworkers and they walk in there and they just complete the paperwork. It's 5 pieces of paper. Why wouldn't you do that? Organ transplants. We have many programs for organ transplants. We source organs. I'll give you an example. We had a family here in Georgia that were going to do it with, they were going to do an organ transplant at Emory Healthcare here in Georgia. And they were going to charge $750,000. We bought the same organ with professional services at Vanderbilt in Tennessee and UAB Birmingham for $138,000. So why aren't you doing that? Why aren't the people that are in control of your expenses working on ways to lower the expenses? Same organ, same doctors, same everything, just $600,000 less expensive. So those are some programs you can look at. And those are, by and large, some of those are short-term issues, but then you have the long-term illnesses, right? So you've got leukemia, Crohn's disease, multiple sclerosis, cancers, diabetes, heart stroke, musculoskeletal. When people have these things going on, they are financially devastated. They're morally devastated. They're scared, and they're worried. And when we talk to them, because we call them, they always say, I need 2 things. They say, I need time and money. I need time to get my house in order. I need time to run my spouse to the doctor. I need time to spend with my daughter. And I need money because these people that have long-term illnesses are hitting your out-of-pocket maximums every single year. So this for them isn't a 1 year $7,000 expense. This is an every year $7,000 expense, right? And if it's a family, sometimes the out-of-pocket maximums can get up to $13,000, $14,000, $15,000, $20,000, plus the insurance premiums they're paying to you, and that is devastating. And so what we did was we started addressing that. We formed a foundation We gave away $70 million last year to pay for people's medical bills. And there are billions and billions of dollars out there that you can access to pay for people's medical expenses. It's free to them, and it offsets those costs to the employer. So we're talking again about enriching lives, enriching benefits, saving them money. They have to be positively impacted by every bit of this, right? It has to be benign or better to the patient, and it has to be impactful to the employer. Then you got to focus on medications. High cost brand name and maintenance medications and high cost specialty medications. So we have programs that we developed for that. We can kind of talk about it a little bit. So we built a pharmacy company, goodness gracious, I don't know how long ago. But we take the same medications you get at CVS or Walgreens or Target or I don't know what the big ones there are, Mark, but and we get those same medications in the same boxes and we ship them to your members for free. And it costs you 53 to 100% less. We wrote over 4,000 medical or pharmacy grants last year. So there are grants in pharmacies, there are grants in medical situations, there are medications you can access that are 50 to 70% less on average. And when you start looking at that, the first thing that happens is about 41%, 42% of your employees now have no copay for their medications. Enriched benefits. So this is back to the man on the moon. Can you make benefits richer and lower the expense? Yes. You give it to them for free. You don't need $25 or $150 or even $1,000. When I'm taking a medication, take Tremfya. We just did this. There's almost $27,000 a shot. Well, we get it for about $6,000. So you don't need their $150 when you're saving $21,000 a shot. Those are the kind of programs you want to kind of look at. When you have high cost medical claims, you know, these people are sick, things happen. But you can find ways to offset these costs, provide the same doctors and hospitals and services, and find other people to pay the bills. It's magic when you start working on these, but you got to find a way, a creative way to have access to these, and you can't do it under the restrictions of a care-based plan. When you do that, we said we have impact to our clients. You know, I think the lowest impact we are showing here is 20%. If you look at the red lines or orange, those are the cost, and we do a thing called per employee per year. It's real simple. You take your total expenses, that's employer and employee total cost, divide it by the number of employees you have on your insurance plan, and there's your per employee per year. And per employee per years range anywhere between 11,000 and 24,000. We just picked up, I was just saying, we picked up a county yesterday. Their per employee per year is $24,000. Our average is about $9,000 to $10,000. Okay, so that's $10,000 per employee per year that we feel that we can impact the plan while making the benefits richer to the members. Okay, and almost always you see this bifurcation where their trend was going this way. We get involved and you're going to get 20 to 52%. And you can see that bottom line doesn't stay static the whole time. It moves up and down a little bit. But by and large, and we talked about on that other slide, the difference between the top line and your cost and everything in between there is savings to the plan. Now, we've had cities and counties in Georgia take those savings and they paid 100% of the salary increases. I know that y'all are fighting to attract and maintain first responder services. They're hard jobs. They'll go to a neighboring city or town for $1 an hour. And these are the things that create the stories that allow you to attract and retain better employees. So now it's storytelling time. So what I want to talk about is every single one of these clients and every single one of these stories, the benefits plan has no copays. No copays. We take primary care copays to $0. We take specialist copay to $5 or $10. We take urgent room to $15, and the max we want to go on hospitals $500. But every single one of these stories also has no cost to the member. So there's a family here who the young lady has Fabry disease. Fabry is a terrible enzyme deficiency. Life expectancy without this drug is about age 36. And it's $1.7 million for her, her husband, her child, her daughter and son. And this happened to be a firefighter that married a young lady that had this, and of course it's genetics, so they pass it to their children. So in Georgia, Faberzyme, which is the medication, is only infused in one place. It's in Piedmont Hospital in downtown Atlanta. These people live in a town about 40 miles west of downtown Atlanta. So the husband was having to take off work every Friday, go pick up his wife, his daughter, and his son, drive back down to Atlanta, an hour each way. It's 4 hours for the infusion. There's some side effects, so you can't drive afterwards. So he has to drive back home. So he's off work every Friday. In addition to that, as his children developed, his son got a full ride to University of Georgia, but he wasn't going to be able to go because he had to come to Piedmont Hospital every Friday, and it was a football scholarship. He couldn't practice football. He was going to have to be out of practice every Friday and Saturday. So what we ended up doing was we got the medicine for free. The medicine for this family was $1.7 million a year. Now, this was a city that only had 140 employees. Their whole spend was $1.7 million a year. And then this one family was costing them another $1.7 million. And they were getting 40% increase, 26% increase, 40% increase. And when it came to me, they were talking about possibly not even offering health care. So we've taken them, this was in 2018. We took them into our programs. They got the medicine for free. There's about a $400,000 comorbidity. There's liver problems, there's sight problems, there's all kind of stuff that goes on with this disease. The son got to go to University of Georgia. We moved the infusion to his dorm. We moved the infusion to their home, so the mother and the daughter have their infusion every Friday, and now the husband can work every Friday. It is a success story. And what I'll tell you is these stories spread like wildfire inside of a company, and our clients, and if you choose to go down this path, find somebody that can help you do this. You can tell the story that when you're at your sickest, when it's your most financially risk, when you have your worst fears of your whole life, that we as your employer can help you better than anybody else. And these stories allow you and your employees to talk about the employer, to talk about how the employer helps us through the worst of times. And everybody knows now that what used to be, this family was known, and everybody knows the sick people in these employers, and they know that's why the costs are going up. And now these stories are turned into a positive, right? My employer helped me with this. My employer did this, and I'm not costing the plan anything, and I'm not causing all the other 800 employees to pay more because of my sickness. It is fantastic. We've got pregnancy complications. These were premature twins back in January this year. We talked about the lung transplant. The bone marrow was terrible. This was a guy that got diagnosed with cancer. They couldn't find it. They were going to send him down to Mayo Clinic in Jacksonville. They were literally going to have to drill holes in his bones from his toes to his head to find this cancer. He had to take off 3 weeks. His wife had to take off with him. They had to stay in a hotel, and we covered the $420,000 hospital bill, the hotel, the food, her salary, and his salary while they were out of work, 3 weeks. Those are the power of these programs. If you know how to go lift up the stones and pull out the money that's sitting underneath there, and you can deploy that capital to your plan expenses and help these people, and you benefit by the fact that you just didn't spend $2 million on somebody's claim. Okay, a little bit about Strongside Solutions. So I was going to kind of transition. That's kind of all my stuff, and but we're privately held. We don't have a conflict of interest. We don't have shareholders, right? We have over 20 years of doing this. We have about 5.5 million lives that we service. We've given away $70 million to pay people's medical bills. We saved over $1 billion in pharmacy expenses. Our team is fantastic. We have the best team in the whole world. I love them. And their whole job is to make a difference to you, to our team members here in our company, and to your employees. We do tremendous broker services. So you got to do all the broker stuff. You got to bid the insurance, you got to market the insurance, you got to explain the insurance, you got to educate the insurance, you got to make sure everything's compliance. We are the Swiss Army knife of broker services. I think that's super duper important. And then the way we kind of get at this is we have a bunch of technologies you can imagine. We mix our technology, which is artificial intelligence, with our staff. I think our youngest person here is probably 40. We're all a bunch of non-spring chickens. And the way that we evaluate things, I think, is really interesting. Data tells the story. Every single one of these clients sent me their data, and what we tell them is not hypothetical. If you send me your pharmacy claims, if you send me your medical claims, we'll do a REX review. A REX review is returned expense review. I think it speaks for itself. And then we turn around and generate reports. This happens to be, here's a 700 life group. This is a 90-day program we have, and you can look on here. They're paying $34,000 for something called Big Tarvey, and we get it for 11 grand. That's 10 employees, right? You can look here. Here's something called Breviact. They're paying $15,000. We're paying $1,300. And it just goes on and on and on. Anyway, we'll return a report like this. There's about $900,000 savings in that one. Here's one that had about 5,200 employees. This is our grant program. And the list is like 4 pages. I had to kind of cut it off because there's just too much to show here. But, you know, $14 million just for this one client, just in pharmacy savings. This is just writing grants. This is just getting the medicines for free. And that's pretty much it. That's our whole presentation. What I hope you learned out of this is insurance carriers aren't your friends. They're publicly traded. They got to make their money, and they're going to do it at your expense. Large national brokers have the same problem. There's a conflict of interest. Healthcare is a continuum that is based on the funding of risk, and how you fund it is very important, because certain funding mechanisms give you no control and other funding mechanisms give you absolute control. And then once you get to where you can have absolute control, if you know how to do optimizers, if you know how to optimize these plans, if you know how to write the words, if you know how to build the programs, if you know how to access the capital out there that you can deploy, it makes a huge difference. So hopefully I've done my job today, and hopefully you found this interesting. And if there's any questions, I can take them. And if there's any opportunity for us to say hello to you, we'd love that as well.
And while folks are asking some questions, I just want to say thank you, Wendell, and thank you, Mark. I met Wendell a few years ago, right before I left office. I left office at the end of 2021, having spent 16 years as the inaugural mayor. And one of the clients that I was fortunate enough to get Wendell to help, their costs had gone up significantly. It was a city here in Georgia, sort of south of Atlanta. They had their medical costs go up from $5.1 million 2 years prior to Wendell up to $7.1 million. And in the first year, which was 2023 of Wendell helping them, he helped them save $2.8 million. That's a significant amount of money. In fact, I ran into the city manager at the Georgia Municipal Association annual conference this weekend, and she just has the biggest smile on her face when you ask her, how did it work? And she said, I'm so glad we did this. And at the work session, when they were approving it, I remember there were 4 items on the work session. We were last. The first 3, each department was asking for money. And in my head, I was adding it all up. And then when we got up, I said to the council, I said, I just want to tell you something. The last 3 people were asking you for money. And I think if you pick Wendell and Strongside, we can save you enough money to pay for all those things. And it turns out that the money they saved in 2023 would have more than paid for the 3 things that they were being asked for in that work session. So it really, really works. And I hope it made sense. And if you've got any questions, please put them in the chat and let us answer them.
Wendell, Mike, thank you guys so much. I think this is a really exciting, difference-making opportunity for my cities and TML. We hear about the rising premiums, and understanding how to deconstruct the industry like this, and having a partner like Strongside who knows how to turn over those rocks and find that money and use the tools that are available to build something for each city and save the money. That's very exciting to me. I want to thank our attendees for joining us today. Please, if you have a question, you can use the Q&A or put something in the chat. We'd love to answer your questions. And if you don't have any questions, thank you for attending today. And I hope to see you at our annual conference or hear from you sometime soon. Please reach out to me. We can connect you to Mike and Wendell so you guys can continue a conversation after this. And if you like that, put that in the chat as well.
Well, we appreciate it, Mark. Mike, thank you for being here with us. And, you know, if there's any way we can help you and your league and your state, we would be thrilled to do that. And it's meaningful and fun.
Not seeing any questions. You can always follow up with us after the fact. So I'm going to say that we're done here today. Thank you, Mike and Wendell, for this session. We really appreciate it.
Thank you. Have a great day.